Hello, everyone, and welcome to this webinar, a function of the Penn TTM Academy. We're going to just start in a couple of minutes. We want to make sure that enough attendees have a chance to join us. So hang tight for a minute or two while people are joining. Maybe all of us as panelists can mute our microphones and videos or something for a little while until everyone joins, and we'll start in 2 minutes. If you're just logging on, welcome to the Penn TTM Academy webinar, where we will be discussing the recently published TTM. We're going to give it just 1 minute start. So welcome, settle in, and we'll get started in just 1 or 2 minutes. Okay, maybe we can now get started. And if I would ask our panelists if they can all join by video as well. So this is a program put on by the University of Pennsylvania. It is known, the program is called the TTM Academy. It's a program that has run for several years now, focused on education, training, and other care for patients following cardiac arrest. So we're pleased to bring you this special seminar where we'll be discussing the recent trial published in New England Journal of Medicine, known as the TTM2 trial, or Targeted Temperature Management 2 trial. If you're joining, that means you are most likely a clinical provider or in another way associated with cardiac arrest and post-arrest care, and we welcome you. One other bit of housekeeping, we actually have applied for and obtained CME and CE credits for today's presentation. So one of my co-hosts is going to put the instructions and information around the CME and CE credit in the chat. Because I'm sharing my screen, I don't see that. So Nate or Nabil, if you could do that for us, please. So, and certainly we can help you after the fact obtain CE credit if you're a nurse, CME credit if you're a physician, and help you otherwise. So it's important as a CME program to tell you that this program was sponsored by Becton Dixon with an unrestricted educational grant, although they had no input in this content and no influence in what we're going to say and are not paying us to do this. None of us are being paid to be here today to speak. So hopefully we can give you as unbiased a presentation as possible. And these slides and content are reviewed by the Penn CME office for bias in the content and such. So hopefully you'll be able to access that if you wish to seek CE or CME credit. Okay. Well, to begin with, what I'd like to do, I'm actually going to stop sharing my screen for a brief moment here. I see that we have over 200 attendees plus so far, so that's fantastic. I'm sure more people will be joining over the next few minutes. We'll start off just by introducing everybody on this webinar. So these include Dr. Michael Kurz. Mike, if you can just sort of wave and say hi. Mike is a faculty member at University of Alabama, where he's in the Department of Emergency Medicine. But he spends a lot of his time managing their post-arrest care programs and taking care of people with cardiac arrest and critical illness. Dr. Ramani Balu is at the University of Pennsylvania. Dr. Balu is in the Department of Neurology, where he's a neurointensivist and has been very involved in neurocritical care following cardiac arrest. Also, Sarah Perman. Sarah Perman is Sarah, if you could wave, say hello. Sarah Perman is at the University of Colorado, where she is in the Department of Emergency Medicine and has been very involved in scholarship around cardiac arrest and post-arrest care, with a special interest in withdrawal of life support and what that means for this population. And then our final panelist today is Dr. David Gajewski. Dr. Gajewski is a professor of emergency medicine at Jefferson Medical College and the Sidney Kimmel College of Medicine in Philadelphia, where he also has been very involved in critical care teaching, education, and research around both sepsis and cardiac arrest care. So we're thrilled to have this expert panel with us today from around the country. All of us have worked together and thought together long and hard about post-arrest care, and in particular about the TTM2 trial. So hopefully we can provide you some insights as to what the trial is, what it isn't, the context for the trial, because I know that many of us around the country are going to be struggling with how to interpret this trial in our practice. So our goal today is going to be to keep this very practical, very clinically oriented, and hopefully provide you insights to help decision-making at your hospital. Okay, very well. So I think what I'd like to do for starters in this webinar is for about 10 or 15 minutes, give an overview of the trial for those who haven't read it, a little bit of a Cliff Notes version, and then the context for the trial. And the context for the trial will include a little bit of the scientific background that led to where we are today. So with that, I'm going to share my screen. Okay. Very good. So Nate or others, if you could monitor the chat since I can't see it when I share my screen, just to make sure in case attendees can't see. Looks like our panelists can see the slides. Hopefully attendees can as well. So let's go through this a little bit. So first off, a little orientation. The TTM2 trial was published just within the last few weeks in New England Journal of Medicine. First author was Joseph Dankowitz, and the senior author was Nicholas Nielsen. I show you their pictures here on the screen. I think the most important thing I can say at the outset, we will at parts during this webinar be critical of a number of aspects of the trial and what it means, but do not misinterpret. We have utmost respect as a group for the authors of this trial. I think we all agree that this was a very ambitious, very well-performed trial. It has a number of aspects of its conduct and design that are rigorous and strong, and we know that the authors have great integrity and they were pursuing an important scientific question. So understand, any critiques we put forth are just an honest and vigorous debate around the science and are in no way to be interpreted as any personal aspersions towards the authors who I believe to be honorable and excellent people doing the best they can under a very difficult trial environment. So let's go through a little bit about this trial. So fundamentally, the TTM2 trial tried to address the following question. Is the value of temperature management after cardiac arrest in the cooling of patients, or is the value in a careful fever avoidance? We all know that fevers are common after cardiac arrest and they may be injurious, but they wondered if that was all you needed and we didn't need to actually cool people to 33. So here's their hypothesis. I won't read all the words on the screen, but fundamentally they wanted to randomize patients to what they called rapid cooling, and we'll get to what that means later. One of our contentions is that it wasn't as rapid as perhaps you might think, to 33 Celsius, or the early treatment of fever in adult patients with out-of-hospital cardiac arrest. Here are their eligibility criteria. Fundamentally, they had to have stable ROSC, stable return of spontaneous circulation after cardiac arrest. They couldn't have limitations of care, so they didn't want to enroll people for whom perhaps comfort care measures were indicated or desired. And the patients had to be comatose after a presumed cardiac arrest. And that term gets confusing, and we may talk about that a little bit later as well. Patients were randomized to either 33 degrees or what they called normothermia, which is that patients had to be under 37.8. If they went above that, they received a cooling device or other treatment for fever. There was a general wide prescription for that. And then all patients received sedation, they were ventilated, and they received fever treatment for at least 72 hours. They also all had a neuroprognostication scheme where neuroprognostication would not be undertaken before 96 hours. And then full organ support defined as hemodynamic support and other things were done as much as possible until discharge. The primary outcome measure of the study was survival at 6 months. So the death from any cause. So this wasn't sort of a specific indication of death related to their cardiac arrest, but basically how many patients were alive or dead at 6 months. And then secondary outcomes include functional outcome, and they used a neurologic scoring system called the modified Rankin scale. It's used more and more in cardiac arrest and other studies. It's a simple but useful measure of functional outcome. And then other secondary outcomes related to quality of life. A number of countries were involved, although it should be noted that a great majority of all cases came from Sweden, United Kingdom, and Switzerland. Those combined were easily 2/3 to 3/4 of all patients. Nonetheless, there were other countries involved as well. They enrolled over a period of time in 2018, 19, and 20, and ultimately, 1,861 patients were included in their intention to treat analysis, 1,850 in their final survival analysis. And this is the cohort. So 930 patients in the cooling arm and 931 in the normothermia arm. Just to show you a little bit of their characteristics. And by the way, I should tell you, these slides are with permission shared from Nicholas Nilsson, who endorsed them, so I should give credit where credit is due. These are the trial slides that he also presented at a webinar where they presented these results a few weeks ago. So the median age was 64, and you see there was pretty good balance and a number of characteristics. One thing I would point out, 80% of the entire cohort received bystander CPR. Also not on this slide, but over 90% of the cohort had witnessed arrest. So we'll get to that when we get to generalizability concerns later in our discussions. Here's some more details. The percentage of STEMI was quite high, interestingly, over 40% of their arrest. That's a lot higher than we see, but again, I don't want to editorialize at this point, so I'll try to restrain myself. 78% of patients went to the cardiac cath lab. And also interesting to note, the majority of patients received a TTM device, either for hypothermia or normothermia management. Interestingly, and this is worth highlighting, 46% of the fever prevention arm actually had fever prevention via a device, a commercial device to manage temperature. So this was not all sort of low budget Tylenol or cooling fan temperature management. Here are their adverse events, and fundamentally, there were no differences in any adversity except for arrhythmia, and we'll get to the meaning of that a little bit later as well. The results were neutral, meaning the rate of death was equal in both groups. There was no signal for death at 6 months, nor was there a signal for modified Rankin scale. So fundamentally, hypothermia or normothermia, one was not better than the other. They both had the same rate of death, the same rate of neurologic outcomes, and I would say also, except for arrhythmia, the same profile of adversity. So the summary of this is the Cliff Notes version of their trial, was that fundamentally that cooling in their trial did not seem to be linked to a difference in outcomes or neurologic survival. Now, I wanted to spend now just a couple of minutes on context, and then we'll launch into our discussion, because I think some of you may or may not be aware of the full context of where did this trial come from, and why are we thinking about TTM at all? Well, TTM's been done clinically for some 20 years, and really it's important to go further back than that. There have been countless studies, one might argue in the hundreds of studies in the animal laboratory with cells, different animal models, showing that cooling animals or model systems after cardiac arrest improved outcomes. So this didn't come out of nowhere. Very, very strong mechanistic evidence from the US and Europe and Japan and other countries showing that if you cool a variety of different animals or cells after ischemia reperfusion, survival is better. And these are mechanistic studies. They looked at the reasons why. So cooling lessened brain swelling, it lessened inflammation, it improved a number of other characteristics. So then there were 3 RCTs that all showed that cooling improved outcomes, 2 from 2002 and then 1 from 2019. All 3 of these trials, and we won't get into great detail on these, I'm happy to do that in the discussion at the end, but these 3 trials all consistently showed a large effect size of lowering to 33, improving outcomes after cardiac arrest. So this is all the background, all the clinical context that led us to this study, and perhaps one might argue this surprising result. Now, this also didn't come out of nowhere from this group. They did a study some years ago called TTM1, where they randomized to 33 versus 36 and found no difference in outcomes. What's interesting to note is a number of hospitals on the strength of the TTM1 trial changed their protocols to 36 and then reported after that change that their outcomes worsened. So this is one out of Melbourne, Australia, and this is one out of Seattle, where hospitals that switched to 36 after TTM1 found worse outcomes. Now, there's much to dissect of why they may or may not have found that, but I think it's a cautionary tale that we all need to be very careful in our consideration of this trial so that we don't have unintended consequences as shown here. And so I think I'll close with the following two slides. I would like to caution all of our listeners, when a trial comes out, there's often a huge rush of enthusiasm. And I show you here two examples in media, one being traditional media, Newsweek magazine, on the right being a blog on modern media, social media. Early in the TTM times, back in 2002 and 3, there was enormous enthusiasm for this therapy. And these sort of reports said, everyone does great, this is the best thing ever, and we can save lives. Then with this recent trial, those who were inclined to not really believe that this therapy worked say things like hypothermia is dead, RIP hypothermia. I think probably both of these are not quite correct. And I would advise all of us to be cautious and not rush to judgment because we need to delve into the science. And I'll end with this slide and then we'll launch into the discussion. In the cycle of many ideas, clinical therapies, or ideas in other spheres, there's often a cycle. And the cycle starts with something like wild optimism, something is brand new and very exciting. In our case, TTM is great for everybody. And then follows despair, studies that show that something doesn't work. And then everyone says, oh, maybe we should abandon this therapy. Maybe we're wrong all along. And then what is often the case in so many different therapies, some equilibrium is reached where we realize, gosh, it's more complicated than we thought. It may work for some people and not others. And I hope that this stage 4 and 5 will be where we are reaching, hopefully with the help of this webinar today. And this is the final thought I would leave you with, that probably the answer that everyone gravitates to are the simple ones, but more complex answers may be where we are at. Okay. That ends my brief little accelerated overview of the science and where things stand. I think what I'd like to do now is turn to our panelists. And by the way, two comments I would make to the audience. We will not be responding to the chat function at all. I see some things in the chat function. We will be responding to the Q&A. So if you have questions, we do want them, but put them in the Q&A. The reason being that the chat everyone can see and we can't moderate and manage it as well. So please do put your questions in the Q&A. And once again, for anyone who's arrived late, we have been awarded CME and CE credits for this, and we will be sending information on that in this as well as later on after the webinar as well. So let's begin. I would like to now turn to each of our panelists to make a brief little statement on their general perspectives on this trial, and then we'll have focused discussion with each of them on different aspects of the trial. So let's go first to Michael Kurz. Mike, any initial reactions to this trial, what you think it means, and your initial response?
So my initial reactions when this trial came out were how well done this is. I have an utmost respect for these investigators. I personally do resuscitation science and know how difficult it is to accomplish a trial like this, certainly spread over so many sites over so many countries, where the healthcare systems are just, frankly, in some settings, fundamentally different than what we're used to every day, or certainly I'm used to at my shop. Other quick observations. I was struck from the trial that if you take all of the patients in the trial, regardless of what temperature they're cooled to or not cooled, 3/4 of them require some type of commercial device in order to achieve their target, whether that target was 33 or that target was, fever suppression at 37.8. 3/4 of them require a commercial device in order to achieve that. And then I was also struck initially at the quality of care that each of these patients has gotten. So we have come in resuscitation science in the clinical application of comprehensive post-arrest care. We have come a long way since '02 when the original trials were published, and truly, those trials were cooling, frankly, were fairly pragmatic, and it was cooling versus standard of care, and those two cohorts in large part got supportive ICU care and cooling, and that was it. And that is remarkably different than the protocolized goal-directed therapy that cardiac arrest patients get in cardiac arrest centers today. And that's reflected in the complexity of the patients that are enrolled in this trial and the care they receive.
No, thank you for that, Mike. Ram, Dr. Balu, any initial comments, reflections before we get into a deeper discussion?
Yeah, so, I would echo Dr. Kurtz's comments that this was an extraordinarily well done study. I think there are a couple of things that I wanted to highlight just as a neurologist and a neurointensivist thinking about this, which is to put this study in context with the other literature that we know about in terms of both therapeutic hypothermia and targeted temperature management in different types of brain injury. So just kind of following up on what you had mentioned in your initial presentation, I mean, there's a large background of literature both from preclinical models and also in humans that supports the deployment of temperature control as a potential neuroprotective therapy. And I think one of the things that has always come up in all of this literature is balancing the potential neuroprotection of lowering core body temperature. And by the way, we think that hypothermia is really working by some function in the brain, either by changing metabolism or altering neuroinflammation or something like that. So the balance is, the potential neuroprotection that you get from hypothermia versus the systemic toxicities that might occur from hypothermia. And what we know from a lot of studies is that, that balance may tilt towards actually favoring hypothermia, and we see a clear evidence for that in things like neonatal hypoxic ischemic injury. And then in some other situations, like in traumatic brain injury, it actually seems as though the systemic toxicities and side effects of hypothermia are outweighed by the benefits, and hypothermia actually leads to harm. And so I think that when I'm thinking about this trial, one of the things that I'm thinking about is that what's important is understanding the burden of degree of hypoxic ischemic brain injury and how that interacts with the potential need for therapeutic hypothermia. So patients who have potentially more severe brain injury may benefit from lowering core body temperature, whereas those that have, say, a less burden of hypoxic ischemic brain injury may not actually benefit. And I think one of the things that jumped out to me in this study was the extraordinarily high rate of bystander CPR, which suggests that the burden of hypoxic ischemic brain injury may not be as great as what we see in Philadelphia or in other places in the United States.
Great. And we'll certainly get to issues of generalizability in our discussion as well, and what that means. But thank you, Ram. Dr. Perman from University of Colorado, any initial thoughts or reactions to this trial?
Yeah, so I think I need to echo what everyone else has said about this was an incredibly well designed and well executed trial, and I think all of us are giving accolades to the investigators for their success here. I do, I did have a couple of initial kind of reactions, which I think have already been discussed. But I think the initial concern was just thinking about who my patient population is, and how does this not change their therapy, but how does this potentially augment and add to what we know and what we can do to provide personalized care. I think one of the things that I'm reassured by is, in looking at this trial, which was supposed to be a repeat of what was done in 2002, is that, we didn't see a regression. We didn't see that normothermic arm have adverse outcomes. That normothermic arm did pretty well as well. And I think what that's a testament to is the bundle of post-arrest care that we provide. And so I think that that's one take-home message, is that, irrespective of temperature selection, I feel like what we are doing in the post-arrest phase is incredibly important, and we shouldn't slide and lose that that momentum. I will also say, looking at the study like the TTM1 trial, I was very impressed and reassured by the neuroprognostic strategies. I think both studies have always laid out a very clear delineation for what they anticipate in terms of addressing withdrawal. And so I thought that was very, very good to see. And I like, progressing forward with the science and thinking about that. And finally, I have to put on my sex and gender researcher hat. And just draw attention to this study that only included 20% women and excluded pregnant women. And, so that does raise a concern. The phenotype of female cardiac arrest tends to be a little bit different than what is described in this manuscript. We know that women have less bystander CPR, they have less witnessed arrest, they have higher rates of non-shockable rhythm. And I think that it really opens questions about how we should be applying this to multiple populations, but especially women were definitely underrepresented in this study.
Dave, thank you, Sarah. Dave, Dr. Geske, any comments? And then specifically, we'll segue into the next portion where I'd like to go a little bit more in depth with each of you on a specific aspect. And we had discussed ahead of time for those listening in different aspects we're each going to cover. And by the way, those of you putting in your questions, the second half of this, we're going to be answering your questions live. I see some of our panelists have answered, which is fine, but we can do most of the questions in discussion format. Dr. Geske, any thoughts and comments? And specifically, why don't we segue into some more deeper discussion? What are your thoughts about generalizability in this study? As was mentioned by Dr. Balu, the 80% bystander CPR rate, 91% witnessed arrest. What does that mean to you? And how do we interpret this trial as whether it's generalizable or not?
Yes, thanks, Ben. I won't reiterate everything people have said because I think we've covered many of the important points, but I will segue into that. And I will echo the fact that I think it's like TTM1, really wonderfully done trial. I also think from a perspective of doing clinical trials, it's important to emphasize that like TTM1, this was able to be done in Europe for significantly less money than it costs to do a trial in the United States. And I don't know the exact cost of TTM2, but TTM1 cost about 2.5 million euros, which is just to compare it to a similar process trial for sepsis cost about $17 million. So that's over 3 times as much. And I think Europe has some things that are set up better in both their academic systems, how they function as academics at their universities, the role of research in being an academic, and then how the EU funds research that we could learn from and really integrate into what we do. For example, if for $5 million we could replicate this study in the United States with the patient population that we see in most of our institutions. So looking at a different amount of shockable rhythm, a different amount of bystander CPR, a different percentage of women in the trials, different ages, the complications of US urban environments. I think we might be able to really bring a real world perspective to this. So
Dr. Geske, if I could jump in, let's talk a little bit more about that, because you mentioned the US. Tell the audience, because some folks may not be fully aware, what is your sense? You've studied cardiac arrest for a long time. What is your sense of some of the basic facts on the ground? Bystander CPR rate, witnessed arrest rate, shockable rhythm rate, shock frequency of the cardiac arrest cohort in the United States that we often see?
I mean, the first thing to say is the US is not a monolith, right? And it varies amazingly from place to place, but you can throw out some numbers, quickly that will resonate with people. In Philadelphia, less than 50% of cardiac arrests are witnessed, and somewhere in 1/3 of the time people get bystander CPR. The number of arrests that get an AED is shockingly low when you compare it to data from Japanese reports from the All Japan Utstein Registry. Then the number of shockable rhythms we have goes way down, and the number of people having ST segment myocardial infarction, either prior to their arrest and then are taken to the cath lab, or have that ECG pattern after their arrest is way lower. So we're just, you're talking about very different patient population. It's in some ways like saying X worked on a group of young, healthy 25-year-old male athletes. Does it work on 50-year-olds of both genders and who have medical problems? And those are two different studies, and we have to really think about that in terms of how we interpret this study. I am not going to say I don't believe the results of the study. I believe the results of the study very much. And I believe that for the patient population they treated, with the time to target temperature in the populations, and with the almost 50% of the 37-8 group getting active management, and 2/3 of those getting an intravenous catheter. These are different ways of doing things, much stricter. So my first point about generalizability was just to think people, I think, need to think in terms of the whole efficacy versus effectiveness, sort of T3 translational research perspective. And that really makes me pause and say, can I leap from this? And then I would, as a devil's advocate, if someone says to me, I'm going to leap, I'm going to go to the normothermia, I'm going to want to know how they're going to operationalize that. And are they going to actually go to normothermia where 50% of their patients get a device? Or are they going to say they went to normothermia and wink and, just start not taking as good care of the patients? And if you do choose to do that, I think that you have an obligation as a clinician and hopefully a researcher to gather really high quality data so that we can study what happens after this in a more rigorous fashion than the good studies like Nick Johnson's and the Australian studies that were done.
No, thank you for that. Dr. Kurz, a little bit more of this, to key off of Dr. Agajski's point about sort of the tightness of control. You very much live in the real world in many ways. You're at the bedside for a lot of these patients, and you see what nursing culture and cardiac arrest, you see what physician culture, you see how different hospitals who send patients in handle it. Help us understand what the differences are between, the care in this trial versus the care at some of the hospitals you work with and see in Alabama.
So to just for a moment to put it in perspective, here in Alabama, we work in a very unique setting. At the University of Alabama, we are essentially the only center, and we are fed by a number of secondary and tertiary hospitals. But effectively, we are the cardiac arrest center, and so we see what kind of care is delivered outside the institution, and that's really reflected in our numbers. Across the state of Alabama, your chance of survival from a cardiac arrest, as published by Graham Nickel and then Modiah out of Rock, as we are a Rock site, was 3%, and it didn't move. And this is significantly lower than the national average until you get treated here in Birmingham at UAB, and your survival rate jumps to 1 in 3. That's to say that the care delivered in this trial as part of an RCT really represents the pinnacle, as it were, of post-arrest care. These folks got device management. They got precision, which was very important in the normothermia group in terms of the temperature they were taken care or chosen to take care of. And then all of the other good practices in the ICU that are part of comprehensive post-arrest care. They got hemodynamic support, though notably not mechanical circulatory support. They got vent management that's consistent with the ARDSNet guidelines. This was truly a group that got, comprehensive post-arrest care independent of what temperature was selected. And while that occurs in the United States at specific locations at cardiac arrest centers, the vast majority of victims of cardiac arrest in the United States are not cared for at one of these centers, and they do not receive this type of care. they're not, it's not going to be that comprehensive. And so even our experience from ROC, when we look back at the retrospective data in 15 after the publication of the first TTM1 trial, we saw that the use of targeted temperature management at 33 dropped off. It actually was about half what it was prior to the trial for folks with shockable rhythms. And then among ROC sites, it dropped to virtually no utilization at all. And unfortunately, I'm afraid that this may be how this, how this study is interpreted by folks who are maybe outside of cardiac arrest centers. This does not say that, this trial does not say that these folks should not receive care, or that you don't have to do anything in terms of their fever suppression. What it does say is, regardless of the temperature chosen, there has to be a precise method of maintaining that temperature. And then it comes along with a bundle of other post-arrest care in order to see the optimal outcomes that you see in this trial. A survival rate of 1 in 2. Despite the discussions we're having about generalizability and the population and how good it is, or how viable it is on the front end, a survival rate of 1 in 2 is quite remarkable, and frankly achieved in the United States in only the best translational models.
Thanks for that. Dr. Perman, in a way, this will be a helpful discussion I'm going to have with you next, because a number of our listeners have asked this question about this time to cooling. So, to review for everyone who may or may not have read the paper, it took on average 130 minutes to randomize. Okay, so that's ED arrival to randomization, about 2 hours. And then it looked like from their temperature curves, goal temperature was achieved around 6 or 7 hours after that. So sort of, arguably around 8 to 9 hours from arrival to goal temperature. There are a number of animal studies that suggest that if you go out that far, you get no benefit from TTM. Now, of course, conversely, in Hyperion, they did see a benefit and they had a pretty similar. Nicholas Nielsen makes this point, and he's correct. The cooling dynamics in Hyperion were pretty similar. So how to explain that difference? And what do you think about the time to cooling in the TTM trial?
Yeah, so I was gonna go a little deeper on this because I was watching some of the questions pop up in the chat box there. But
That's right. So this will be efficient. You can answer.
Yeah. No, so I think it's a really important point. What we do know from the study and from the data that was presented is that, as you mentioned, randomization happened after approximately 140 minutes, and so there was a time frame there. And then looking at their temperature curves, you can kind of see when they hit sub 34 and when they hit approximately 33 degrees Celsius. And so it really does kind of stretch you out to about, as you mentioned, Ben, anywhere between 5 and 8 hours, depending on what happened during that time frame of randomization. So I think that's a little bit of an unknown, is not really knowing at the front end what the delay was. But as Ben just mentioned, we do know that there's a fair amount of injury that happens in that immediate time frame. It's not just a low flow, no flow state and you have injury, and then when you reperfuse the brain, all of a sudden everything is off and running. We actually know that patients do still experience a reperfusion injury. And so I think that's why most of us are very sensitive to early initiation of hypothermia. And Ben, what you're referencing, I think, which is a phenomenal study by one of our colleagues, Dr. Bob Newmar, looking at animal data where they delayed initiation, and they found that if you delayed up to 8 hours, it really negated the effects of hypothermia in neuroprotection. So, I think it's something that we all need to think about and consider as we're analyzing this data and thinking about how to implement something similar, or as we're thinking about other questions that we have. I think, the ongoing clinical trial right now in the United States, ICECAP, is looking at duration of hypothermia, but the inclusion criteria require that you're at goal temperature within 4 hours of your arrest, not return of spontaneous circulation. So I think, there's still a lot of questions that we have, but I think that we have a fair amount of data and a fair amount of inclination that early initiation is better. And when we're looking at the TTM2 study and thinking about what that delay might have caused, if we are looking at 8 hours, according to, Che et al. and CCM and Dr. Newmar's work, that would tell us that maybe we've kind of missed an opportunity.
And I'd point out for listeners that Dr. Newmar at University of Michigan has done work on this, but there are a number of others. Nowadays in a variety of animal models where they looked at early versus late cooling. And the general consensus from all of them was the longer the time to cooling, the less benefit you got from it. So it's all very internally consistent. Also, it should be noted that there's a literature looking at the mechanisms of post-stress injury, inflammation, reactive oxygen species generation, other things. And many of these things are kicked off within minutes of reperfusion, minutes to hours. So there's good biology to explain why timing might be important. Now, Sarah, though, then let's play devil's advocate, though. Some might say, well, Hyperion had the same cooling curve, and so are we playing it both ways? Are we critiquing TTM2, but because Lascaux et al. And Hyperion had a positive trial, we're not critiquing them. So are we cherry picking? What's different about the Lascaux trial where the delay may have still shown benefit with cooling?
I think it might come down to what we've all been describing as this very different patient population. And so, I suspect that in a, again, as we've kind of alluded to, with a fairly, potentially not as injured population, maybe it doesn't matter as much. And maybe, we are nitpicking, and really we could do 33, 36, 37 and a half. We could do 12, 24, 36, 48. Maybe it's just, the differences in the actual cohort and not necessarily the intervention per se.
Right. So for those who don't know, the Lascaux study, Hyperion trial, looked at very sick folks, PE or asystole, and their top survival in one of their groups was 10%. So these are much more injured patients. So it may very well be that you still get some benefit in really injured patients. But if you're going to take a relatively healthy population post-arrest, a relatively less injured patient population, and delay the cooling, it may just not matter so much what you do. Am I summarizing your statement pretty well there, Sarah?
I think so.
Now,
In a much more coherent way. Thank you.
Oh, no, please. You were superbly coherent. Now you have some special expertise in withdrawal of life supportive care, WLST it's called, withdrawal of life supportive care. What do you think? Like, was this trial doing it right? What do you think of it? How should we apply knowledge around that?
Yeah, so I think it's a really great discussion. I will say, as another plug for this study, and one of the things that I think about the TTM1 trial as well is there is just such a wealth of information in the appendix. So I would actually encourage anyone who's listening to us chatter on to not just look at the actual paper in the New England Journal, but also to pull the appendix. I think there's a lot of really important information there that sometimes gets a little bit overlooked. But I will say, in terms of neuroprognostication, I'm certainly not the expert that Dr. Balu is, so I'm not going to go too far into that. But what I do want to talk about a little bit is just the withdrawal of life-sustaining therapy. And so, one of the things that in this study they were very attentive to was this notion that if you're still alive at 96 hours, everyone would be evaluated by a blinded assessor to establish neuroprognostication. And I think that's commendable. Recent white paper that was written from the AHA-UCC committee was looking at the recommended time. And I think, the recommended time for neuroprognostication in some of these cohorts, especially when we're studying them, should be upwards of 5 days out. I think that's the appropriate time frame, especially when your outcome is survival and neurologic recovery. I think, if you take a look in the appendix at tables S2 and S3, you'll see really nice tables about when withdrawal did actually happen. And I think what's really interesting is they do describe, if you're alive at 96 hours in the ICU, you would have a blinded neuroprognostic assessor. The problem was that there were a handful of patients who had withdrawal for neurologic reasons prior to that 96 hours. And my take home with that, as I was reading through the paper and thinking about, again, study versus real world, is if such a phenomenally protocolized study that was so well intended, even this study had early withdrawal for neurologic reasons at a time frame when we have no neuroprognostic tests that's appropriate. I think it's an interesting realization that this is a true problem. It's a real problem. And again, if we're not careful, it's a little bit of a slippery slope, because I think, when you start removing portions of a bundle of care, my fear is always that you're going to lose other important aspects of that bundle of care as well. And so I think it's something we have to be very cognizant of and watch. And in reviewing those tables, or the histograms, we don't have numbers, so I can't give you a statistic. But there is a clear number of people that fall into that green category of having an early decision and an active withdrawal for a neurologic reason.
Thank you. No, great comments. So then finally, and then we'll turn to answering
And
questions.
can I just throw in one quick thing there? Because Sarah mentioned tables 3 and 4. And if you look at table 3 in the supplement to TTM2, the biggest spikes in withdrawal of care are the hour before 96 hours and the hour after 96 hours. So people were waiting for that time, following the study protocol, but they still had a sense in some of these patients that the decision should be made. And I'm not saying they didn't have the data, but maybe in the real world, these would have had care withdrawn on day 2.5 or something. And so they waited for longer, as the study suggested they should. But there's a very interesting spike right around 96 hours.
And to follow up on that too, Dr. Gasky and I have chatted about this. There's no description about who these individuals are. We don't know if the folks who had early withdrawal are in one arm versus the other arm of the study. We also don't know if it was all of the individuals who had non-shockable initial rhythms. We just don't know who they are. And so I think, there's questions there about who are those, subjects where somebody said at day one that they're not going to recover.
Dr. Balu, maybe I can turn to you for a little bit. I think one of the issues that is going to be much discussed about this trial, and we've had some discussion on, is neurologic injury. I mean, because we think that's sort of the ball game here. TTM may benefit neurologic injury. And that surrogate measures of that might be increased intracranial pressure, other sorts of things, but we don't routinely measure these things. So, we often talk about bystander CPR, yes or no, being reflective, but that's not always the case, is it? And help us understand what the state of neuromonitoring in this trial or in your experience.
Yeah, I mean, you're absolutely right that when we're thinking about this, so our ultimate goal is to improve neurologic function. And so, the therapies that we're trying to implement are those that decrease what I would call the burden of secondary injury. So that's the injury that is continuing even after return of spontaneous circulation. And what's always been interesting to me, and perhaps this is because cardiac arrest is a disease that often gets cared for in non-neurologic ICUs, is that the brain is usually not really monitored at all in this post-arrest period. One of the, I guess, common ways of monitoring the brain that I think is being increasingly adopted is continuous EEG monitoring. But there's a lot of information from the EEG that may tell you something about the degree of brain injury that's not really being utilized in the upfront period. And so EEG is most often used to identify seizures and then treat seizures. But we know from a lot of literature that there are EEG patterns that are associated with more severe forms of brain injury. I think one thing that would be interesting, and perhaps it might even be able to be done as a post hoc study from TTM2, is really trying to stratify the patients that were enrolled in this study into kind of burdens of brain injury, either by EEG patterns, or if they did this similar to TTM1, where they actually got a lot of biosamples and have the ability to measure serum biomarkers that give you an injury severity, that might actually allow you to identify if there are some groups of patients that have more severe brain injury that benefit from this therapy. In terms of other types of neuromonitoring, there are other ways of monitoring kind of either brain function or the adequacy of cerebral perfusion both non-invasively, like with near-infrared spectroscopy, or invasively, say with things like brain tissue oxygen monitoring or intracranial pressure monitoring. And often, invasive monitoring is not possible in these patients because of their need for systemic anticoagulation or other therapies related to the reason for the cardiac arrest. But I think it's something that in the future, those types of monitoring therapies might actually be able to be incorporated to both stratify patients in terms of the degree of brain injury and also perhaps say guide the dose of therapies like hypothermia. So I think TTM2 was very similar to other large randomized trials in that it was very well done. The critical care was excellent, but the amount of actual brain monitoring, I mean, we can't say for sure because they don't really comment too much, but I suspect that there were very few, if no, patients that had invasive neuromonitoring or other or using the EEG to kind of titrate therapies in that way.
Yeah.
So, during this time, the brain is really a black box, and then we wait and then do the neuroprognostication.
Sorry to interrupt you. Yeah, I think in this trial that they certainly didn't include in their trial presentation neuromarkers or serum biomarkers or EEG. My understanding from talking to some of the investigators is they have a lot of those data, and some of the sub-analyses to follow will include. So, there's much yet to learn. And I think over the next 6 to 12 months, a number of sub-analyses will be submitted for publication and published. And those will help us flesh out the understanding, which, by the way, is another really important reason why I caution all of us listening, attendees, panelists, to just pump the brakes a little bit before we do any wholesale changes to guidelines, because we need to understand this really complicated study a little bit better, I think. There's been some discussion about how the guidelines need to change, and I'm not so convinced that a neutral study with no evidence of harm requires a guidelines change at this point. But let's turn to some questions. And Dr. Bali, while we're talking, maybe I can help sort of direct some questions. Is it true that the brain runs hotter than the body? This is a question from one of our attendees. And therefore, what we think of as managing at 37 may not be really reflective of what's going on in the brain.
Yeah, so there, in general, it does. It is true that there's a gradient between brain and body temperature. So the brain temperature is usually warmer than core body temperature. I will say that that correlation between core body temperature and brain temperature is not really all that well worked out. And so we're making an assumption that when we are controlling bodily fever, that we're actually controlling brain temperature, or that when we're cooling the body down, we're cooling brain temperature down. But I think that's an assumption that we don't really know for sure, because we don't measure brain temperature during routinely in the ICU, unless there's an invasive monitor that allows you to do that. But that would be something that would be, I think, quite interesting to look at, and in future studies.
Yeah, I'm going to address a part of a long question myself, and then I'll throw some more out there. One of our, and we won't mention names of any of the questioners because we haven't gotten their permission whether they'd want it or not. So I'll just say one of the folks attending has asked some good questions about the practicalities of cooling more rapidly. I think this listener heard us say that 8 hours to goal temperature is too slow. And they correctly ask, well, gosh, can you get it much faster than that? And I would just say that in the IceCap trial, where a US trial where the requirement was to get to 4 hours to goal temperature, they've enrolled over 200 subjects. So at least proof of concept, it is possible to get people cooler faster. Is it easy? No. Is it a lot of work? Yes. But those may be what we don't really know from this current trial is would rapid cooling. And Nicholas Nielsen uses that term in his hypothesis, but I think it's incorrect. Goal temperature by 8 hours, I would not call rapid. And among those patients who get to goal temperature by 2 or 3 hours, would we see a very different outcome? But let me turn to some other questions from other folks. One thing, our listeners, I don't know how many are from US or Europe, so this might be an interesting point to elaborate on. And maybe I'll direct this at Michael Kurz. One of our questioners said, don't they have physicians on the ambulance pre-hospital in Europe in many places? And would that have made a difference in some of these cases?
So the answer is, so the questioner, the unnamed questioner, correctly points out that for those who are unaware, the setup for the EMS system in the United States is very different than our colleagues in Europe. In the US system, the highest trained provider is typically a paramedic. There are some specific large systems that have a physician who would respond, but they would only respond in like settings of mass casualty incidents or such. And those are only in the very largest cities, for example, Houston or Chicago or New York. But in the vast majority of the United States, the highest provider you may get is a ALS provider, a paramedic, as it were. And that's very different than in Europe, where the model is very much physician-driven and physician-run, even in the outpatient or the pre-hospital setting. And the physicians do not just respond to the largest or most catastrophic events. There are physicians routinely in the back of an ambulance. Now, would that have changed anything in this trial? I don't believe it would have changed a whole lot in this trial, as most of the criteria are not physician-based prior to enrollment, and are pretty much set by the Utstein guidelines. And so there's no like pre-hospital intervention that might have changed to make it less generalizable. What I do think is very different is when we talk about the populations involved. In the vast majority of this trial, you had a bystander CPR rate of 80%, right? To put that in a VF or a shockable rate that was very, very high as well. To put that in perspective, in the US, nationwide, only about a third of cardiac arrest victims receive bystander CPR. And even in the best systems with telecommunicator CPR that has been widely deployed, like say, for example, the state of Arizona, we still only see 60% bystander CPR rates. That's just one way in which the pre-hospital care is very different between the United States and our colleagues in Europe, and may additionally provide some of the difference we see in the real world application of this trial.
Thank you. That was very helpful.
And we just step back to the speed of cooling question.
Sure.
I think clearly you can get people cool quickly, and if you dig into the Bernard landmark paper, I think there's a lot of meat in that paper, and some of that meat is that they started the cooling in the pre-hospital setting by opening up the people's clothes and then putting the kind of ice bags you'd use for a sprained ankle onto the patients. And then they continued that mostly with packing people's necks and axilla and groins in ice on arrival in the ED, and they were able to get people to target temperature in about 120 minutes in that trial. So you can do it, and then if people are interested in hemodynamics after arrest, they did a lot of interesting things there. The question now is, will there be any will to investigate the speed of cooling? Because a lot of people think, cooling doesn't work anymore. And I think one of the good things in IceCap, as you pointed out, is that there's a 4-hour to under 34 degrees. One caveat to that is the most injured patients are the easiest to cool. So you can get a very injured patient down under 34 quickly. And that's a concern with selection bias toward people who won't do as well in the IceCap trial.
Let's do another question. I think we have to turn back to the one adverse thing that was significant in their panel, which is the arrhythmia. And one of our questioners asks about this. Dr. Perman, maybe you want to take this one? So there was an increase in arrhythmia. And by the way, they define arrhythmia as any cardiac rhythm disturbance with hemodynamic consequence. So in other words, it had to have some consequence, but that consequence was not described. So we don't know. And I asked Nicholas Nilsson this on another webinar, and I didn't get the clearest answer, honestly. So what do you think of this? Do we have to worry about this arrhythmia thing? What does that mean?
Yeah, so I think I think it's a great question. I think it's got a lot of people concerned because we've classically said that there's no difference in adverse events when we talk about 33 and 36, and we know that from the TTM1 trial. We know that from this prior data that there was no difference, and so I think it's interesting to me that in this trial we did find a difference, or that the investigators did find a difference, and so I think there's a definition of what exactly they mean by that is important. I will say what we are presented in the data, if you look again at the appendix, I hate to harp on the appendix, but it's really pretty informative. They do show indications for rewarming. And so they do talk about indications for when they felt like they needed to rewarm and if there was a serious adverse event. And they do delineate dysrhythmia or arrhythmia as being one of the bigger reasons for why they did rewarm, which is interesting. A lot of us would rewarm maybe a degree or two, not rewarm all the way back to normothermic, but so we don't really know what happened there, but I do think, there is a description in the appendix of the patients who did get rewarmed, and a lot of times it was for symptomatic bradycardia, which we know has an ability to respond to just a slight budge in temperature. So I think that's one little insight into maybe what they were finding, or maybe what they were responding to, and what they recorded. But I will also say, and I think we've talked about this as a group. A difference in symptomatic arrhythmia or arrhythmia that causes hemodynamic instability. It's interesting that didn't predict a worse outcome than for the hypothermic arm. So we still have a negative trial with similar outcomes. So while there was maybe something that happened, and maybe something that happened that was temperature dependent, it didn't portend a worse outcome for that arm of the study. So I think we need a little bit more information to understand exactly what it is and why it changed from TTM1 to TTM2 in a fairly similar cohort with the normothermia versus 36, which shouldn't cause a change in dysrhythmia. But I think there's still questions that we need to kind of understand exactly how that was recorded, what it was recorded as, and to take home the message that it really didn't change the outcome.
Great. Dr. Kurz, another question. A comment was made by one of our listeners about these studies, one from Seattle, one I cited in my earlier thing from Australia, but there have been a few others as well, showing that when hospitals switch to a 36-degree target, things seem to get worse for them. What do you think? Is it the temperature, or is it other things? Does it matter? And how do you interpret that? Because I think many of us worry, gosh, are we now going to switch to normothermia and have the same cycle repeat itself where hospitals will have worse outcomes? What do you think, Dr. Kurz?
Yeah, so the two studies you reference are from Seattle are Nick Johnson's, which is in 2019, and then Janet Bray. Hers is from the Australian group in 2017. And Janet Bray is that group is essentially Stubb and Bernard and a bunch of the folks who are involved in the original the original hypothermia trial in 02. I think what we see is much like you described your curve with the pit of despair, as it were, right? I think what we saw after TTM1 was that a large number of folks, many centers went to 36, and then there was some creep when we went to 36, right? So they chose 36, but maybe that was interpreted as I just have to prevent a fever. Maybe I don't really have to apply a device very quickly. I think what happened is, in addition to changing the temperature target, there was also some relaxation of all of the other parts of the bundle of comprehensive post-arrest care. And so what you saw in both of those trials, now, frankly, both retrospective, right? Both observational. What we saw in both of those studies was a reversion of the gains we saw from the original choice at 33. And so you saw a trend line in the Johnson paper, you saw a statistical difference. In Bray's paper, you saw a trend towards worse survival and worse neurologic outcome. I suspect what that meant is in the application in the real world was as you described at the beginning of your remarks, Ben. There were some folks who decided that TTM1 meant that, in fact, TTM was dead, right? And 36 was simply fever suppression. And what that meant is there was some reversion in the care that was provided for these folks. Let's be clear that what TTM1 and TTM2 both tell us is not that 33 versus doing nothing is the same. That is not what these trials describe. And frankly, I think if you spoke to Dr. Nielsen, they would argue that I would agree that that's not what this says. What it says is that you have to pick a temperature, and that these temperatures with the rest of the bundle would be equivalent, right? In terms of the the therapy and the outcome provided.
I would add one thing to that, which is that, you know, if you look at the temperature curves for TTM2 in terms of the hypothermia and normothermia group, and then compare them with the temperature curves in HACA, you actually, many people I think will say that the normothermia group in TTM2 is similar to the normothermia group or the no TTM group in HACA, but that's not quite true. There is actually a clear difference and a higher core body temperature in the patients that had no TTM in the HACA trial. And it very well may be that is the burden of fever that might be worsening outcome. And what Dr. Kurtz is saying, I think, is true, that after TTM1 came out, there probably were a lot of people, even in centers that do a lot of TTM, that said, all we need to do is give Tylenol if there's a fever, and we can, probably do as well as we did with this complicated hypothermia. So it's a point that's worth kind of thinking about.
No, thank you. Let's get to a few more questions. And for those listening in, we had set a time from 4 to 5:30, but of course, everyone has other things to do. I think we'll try to end a little bit earlier than that, probably 5:15, 5:20. I would point out that I put a couple of resources in the chat. So if you look in the chat, a link to a podcast that we've recorded that summarizes some of the points that have come up today. I also put a link to the CME and CE credit documents if you're interested in getting that. And we'll follow up with an email to all attendees offering CME credit for attendance. But let's return now to another question that's come up. So one of our listeners asks, well, we've talked a lot about severity of illness. What tools should clinicians use? Like, let's say you're at hospital X and you're sort of buying this argument that says, well, maybe normothermia is fine for the less injured, but hypothermia is more important for the more injured. By what criteria? Like, what should they be using? And I open this maybe to Dr. Gajewski first, and then others can chime in as well. Dave, what should we be using as a practical matter? Because nothing's validated. So what's your best guess?
Yeah, so great question. And I think that is one of the keys, is being able to, a patient has return of spontaneous circulation in your emergency department or in the pre-hospital setting and is brought to your emergency department. What can I do immediately to say, I think this person may be able to get 24 hours of normothermia and they'll be fine, or I think this person is more injured than that. And one of the ways that I sort of started thinking about these people and was to draw like a quadrant of a graph, and on one axis would be cerebral injury, and on the other axis would be cardiac injury. So you'd have one group that is either very minor or has no injury. You could think of those as your one shock wonders who come in and they're a little goofy, or they're waking up and saying, what happened? Then you have people with profound neurologic injury who don't have much cardiac injury, people with profound cardiac injury who don't have much neurologic injury, and then people who have both. And those are very different groups of patients who need very different therapies. So how can you do this? I mean, I would encourage everyone to read Cliff Calloway and his colleagues' JAMA open paper that breaks these people into groups like that and shows differences in outcomes in different groups. when they have different injuries. And so at 33 degrees, there's a different outcome if you have cardiac and cerebral injury versus if you have cardiac alone. And then there's the group that doesn't benefit essentially from much therapy at all. And those are the people whose brains are profoundly injured when they come in and show signs of severe cerebral edema or malignant EEG patterns. So I think if you can start thinking that way, and then Nishikimi and Taku Owami over in Japan. Dr. Owami's is at Osaka University, and Dr. Nishishimi, I think, is in Nagoya. And they've created a score that basically feeds in how long was the arrest, what was the initial rhythm, what's the initial lactate, what's the initial pH. And they've looked at that score in a derivation, but then they did do an external validation of it. So I think that we need to start using things like that and seeing what results we get from that. And I think if we honestly used those approaches and saw what happened at different temperatures, we'd start to realize that there are some people who don't need cooling or just need to have a fever prevented. And there's some people who maybe need extended periods of cooling. And then the next step would be being able to decide something at 24 hours to say, are we ready for this person who hasn't shown signs of waking up to either be rewarmed, or do they need more therapies at that point in time?
And to Dave's point, for those listening in, lactate is one often used, but poorly, not the best validated, but there are some data supporting that lactate and lactate clearance correlates with severity of injury and outcomes. And there's other markers as well. But I do think, in my opinion, that question comes from a very important place, that one of the biggest knowledge gaps in our field is understanding how to phenotype these injuries. Because, as we said earlier, bystander CPR presence or absence or the initial rhythm is not necessarily so tightly correlated with the degree of injury, which has a lot to do with other factors, genetics, quality of CPR, all sorts of things. So,
and then, there's the obligation to try to save and salvage as many patients as can be recovered after cardiac arrest, but there's also the obligation to identify the patients who can't be recovered and help the families recover as best they can after a cardiac arrest. And I think I'm not in ICU doctor, but I spend enough time following up on these patients that I think if there is no chance of survival and you can tell the people that at day 3 instead of day 14, I think you're doing them a favor.
Yeah, I think that's right. I'll take another question quickly. Someone asks if they couldn't cool them down fast in a well-done RCT, there's very little chance that would go faster in the real world. And we have talked about, I think the listener has a point, and we have talked about ice cap having goal temperature at 4 hours, but that's not a fair comparator because that's not the real world either. I would say that to the listener, maybe, but maybe some people can. And I would also say that we're not done with our technology development in this space. There are other devices, other ideas on how to cool faster. So I think it's one of these things that first we have to show among patients who do get cooled quickly that it makes a difference. And then there may need to be investments in newer technologies and ways to do it better.
Yeah, and ice cap has the brilliant design that you start cooling as soon as possible, and then you have to get them under 34 to randomize them, right? Not unlike the Australian goal-directed trial where you had to give antibiotics before you could randomize a patient to a therapy, right? So that's a brilliant part of that. The pushback I would give to the question is the problem in TTM2 is it's 130 minutes to randomization. So you just have the people hovering there because you can't start cooling them, because if they get randomized to the arm that doesn't get cooled, then you've screwed everything up. So you're wasted a period of time where, I mean, we get people to target temperature in the time it took them to get them to enrollment, right? It's not always, but we do. And so that's a period of clinical opportunity that disappears in a randomized trial. It's not a criticism of them to actually get people randomized when they're comatose in an hour, in 130 minutes is unbelievably good. It's not a criticism, it's a compliment, but it's a limitation of doing clinical trials.
Great. Well, let's cover a couple other questions. So let's see here. Another question. Here's one that I think is related to the timing thing. Is there a time where it's too late? What do you guys think? Is there too late to cool? Is it like TPA, that if the stroke happens 6 hours before we say no TPA, it's just not worth it? What do you guys think? I'll put that as a jump ball for people.
I mean, there probably is, but I don't know what the time is for that. And the reason why I say that is that the processes that lead to secondary brain injury continue not just for minutes after ROSC and not just for a few hours, but they probably continue for several days. And there is probably a time frame in which cooling is optimal. And then there's a time frame in which other therapies might actually be more efficacious. And I think this is where clinically relevant animal preclinical models actually come into play. So in the field of neonatal hypoxic ischemic injury, animal models were actually, large animal models, including swine and sheep models, were instrumental in identifying that, I believe, 72 hours of cooling to their target temperature was optimal. And then that was subsequently proven in a randomized study that looked at longer cooling durations and greater depth of hypothermia. But something similar to that kind of approach can be used in adult cardiac arrest. And I think, the issue that hasn't really been worked out. There's a lot of animal models, but there are not a whole lot of clinically relevant animal model studies where you're actually caring for these preclinical animal models in the same fashion that you might be caring for human patients and replicating the clinical scenarios closer. But I think if you did that, you probably would be able to identify this optimal window.
I just addressed one other question. A very good question in the audience was, what's the bystander CPR rate in other studies? Because we want to have a direct comparator. So I just put a link in the chat to a little file that shows some of the rates of bystander CPR in a number of studies, where we line up TTM2 versus a number of other recent studies. And you can see in a similar population, that is patients who arrive after ROSC, the bystander CPR rate in TTM2 is much higher. So if you click on that link, you'll see the rates in other studies. But for example, in the Johnson paper is 47%, in a large out-of-hospital cohort, Chananel 47%. In the Japanese study that Dr. Geske referred, Nishikimi, it was 52%. So much higher rate of bystander CPR. It's also a little bit more confusing than that, because it's how long was the bystander CPR and to what quality? In TTM1, the EMS professionals got on scene really fast, shockingly fast. The median was like 1 minute. I still struggle with understanding that. So if bystanders are doing medium quality CPR, low quality CPR for a long period of time versus just 1 or 2 minutes, it might matter too. So this is another reason why just the bystander CPR rate alone is probably not the best marker, but it must be said that the bystander CPR rate here among resuscitated people who arrive at the hospital is much higher than in other studies. And this is not so much a critique, but rather a compliment to the communities in which these studies were performed. I wish we had a bystander CPR rate that was that high. In Philadelphia, it's well under half that high. So that's a problem as well. I think I don't want to overextend our welcome. It's getting late here in the United States, and God forbid anyone is here in Europe or Asia, it's even much later. So I want to thank everybody for participating. And once again, I'd remind listeners that we have CME credit and CE credit available for those who are interested. We will send a follow-up email to all participants with some resources and other links as well. And just to say, this was a program of the Penn TTM Academy, which is a multidisciplinary program focused on post-cardiac arrest research, education, and we have a number of upcoming programs. You can check us out at penntm.com. Penntm.com will show you some of our upcoming events. We're doing a live course in the fall. We're doing some other programs coming up as well. So you're welcome to check us out. And with that, I want to thank our panelists, Drs. Kurz, Balu, Perman, Gajewski. I want to thank also Misters Abdulhay and Sands, who are our coordinators working with our team, who helped with some of the technical aspects of today. And with that, I think all of us need to, my one big take-home point that I'd leave you with, let us not rush to judgment. I personally will advocate at Penn that we not change our protocol or change our anything we do quite yet. We really need more time to process this. My inclination is that we'll end up with some hybrid where patients that we deem are more injured will get cooled, but we will likely do more normothermia for patients who are deemed less injured. And with that, I think I'll leave you to your evening. Have a good afternoon and evening. Thanks so much, everyone.
Thank you.